Well, I think CheckMate 914 is a study that had a more complex design, because we had part A, we had part B. So what is the difference? And I think, in part A, what we aimed for is really comparing ipi/nivo versus placebo. And that part has been released already, so we have seen that that specific combination did not improve disease-free survival. So in part B, we investigated nivolumab versus placebo, and for that specific part, so there we expect it to be less toxic because of the single agent that we used, and that has been confirmed, I think, by the data. So we see less toxicity and better tolerability when it comes to the single agent approach, but it did not really reach the pre-specified endpoint. So again, in that study, also the single agent use of nivolumab did not improve disease-free survival. It did not reach significance, let's put it that way. So we have seen a trend, but not significance. Those studies, they run for a long time, and so basically what we considered is that maybe with all the other single agent therapies advancing in clinical trials, that single component has been built in. So at the time being, we did not have the readout for ipi/nivo, of course, and so the question has been, we would like to build up adjuvant treatment to be as tolerable as possible. So that's why we confined it to 6 months of exposure instead of 12 months, which has been the case for the other studies. So that is one difference towards the other studies that have been conducted. And for the single agent component, something we would like to understand is what does it mean in the adjuvant setting? What about tolerance? What about toxicities that lead to discontinuation? And if you improve that part, how does it affect the primary outcome of the trial? And so that was the reasoning really for building up part B. And I think what we see is a trend in that cohort of CheckMate 914. Unfortunately, it did not reach a significant level, but what we see is that there is efficacy of the immune components in specific subgroups. And I think that's also reassuring that immunotherapy per se has its role in the adjuvant setting of renal cell carcinoma. Yeah, I think that debate will continue. What we have seen is, so far, out of 4 studies, 3 are negative, 1 is positive in terms of the primary endpoint. Keynote 564 now reported robust overall survival benefit in different subgroups. So I think, that makes it easier when it comes to the choice for the adjuvant treatment. It would have been, I would say, worrying if we wouldn't have seen any activity of the adjuvant therapy with nivo or nivo-ipi, and I think that's not the case. So and that builds up evidence level for the adjuvant treatment, but it also questions, what is the best cohort of patients to treat. So what we have right now is TNM classification, and we go with that, and I think that might be not the best way to describe the risk that patients have. And I think when you look into the subgroups of other trials, the association and the therapeutic efficacy seems to be stronger in specific subgroups, such as sarcomatoid or PD-L1 positives. So I think that all plays a role when it comes to counsel patients in regard to the adjuvant treatment. And these are different components that you can really use in your daily practice to make the recommendations.